Thank you for joining us. Thank you for joining us for our departmental grand rounds. And I'm very happy to introduce today's speaker, Dr. Renato Roxas. Dr. Roxas is a native Metro Detroiter, and I didn't realize that we had several things in common. But the first thing that is not in common is that he did his undergraduate degree at University of Michigan, but then went to my alma mater for medical school at the University of Cincinnati, go Bearcats, and came back home to do his residency in the combined internal medicine pediatrics program at Wayne State University. And then after that was a pediatric chief resident. So you see there's a theme here. And since then, since he has finished his residency, has done quite a bit, both in the departments of internal medicine and pediatrics, but also in the community. He's been very involved. Now, one of the stories I like to tell about Dr. Roxas is that when he was a resident, he did, like many other residents, the community peds rotation. And part of that rotation was to do a shopping assignment where the students were given, the residents were given a virtual budget, and they had to do various things like go grocery shopping and pay bills and get birthday gifts and that type of thing. And they had a very limited and very strict budget. And Dr. Roxas and his group were the first people to be successful in completing that assignment with a positive cash balance, I must say. But the way they did it was, do you remember, Dr. Roxas, what you guys did?
I don't, actually, I don't.
They sold their food stamps.
Oh, yeah.
they sold their food stamps.
Yeah.
And so after that, I had to tell the residents that you have to be creative, but you have to be legal, because, selling food stamps, $2 for one, by the way, is not legal. So anyway, it just shows you, though, how creative he is, how innovative he is, and how invested he is in making sure that, his patients in the community at large get the best they can. So without further ado, Dr. Roxas is going to talk to us about opiate prescribing in an era of extreme scrutiny. Thank you.
Thank you, Dr. Smitherman. I had totally forgotten about that. Maybe it shows that I'm comfortable with breaking the law too. I don't know. Anyway, so today we're going to talk about prescribing opiates in this era where we recognize that there's a problem, an opioid epidemic that has occurred. And so because of that, physicians have come under extreme scrutiny when prescribing them. And we're not so much gonna say exactly if and when you should prescribe opiates, because I think that's gonna be a very individualized decision. But we are gonna spend a lot of time talking about things you can do if you decide to prescribe opiates to make sure you're doing it in a safe manner, in a way that is making sure the patient is safe, and also to make sure that you, the provider, is safe. I'll just quickly, so anyway, there's a slide about Donald Trump, but I'll skip over that. Anyway, so we'll start with a case just to kind of get you thinking about things. And this is a real patient of mine. And I think if Eric McGrath is on the call, he also co-managed this patient with me. This was probably about 10 years ago. Anyway, RC is an 18-year-old with lumbar myelomeningocele, hydrocephalus, status post VP shunt, paraplegia, neurogenic bladder, and chronic bilateral ankle osteomyelitis, who's coming for an acute visit to see me in the clinic. He's had left hip pain for 2 months. He states that he was transferring from the toilet to his wheelchair when he heard a pop, followed by some acute pain. Now, any movement of his left thigh causes pain in his groin, and it's not responsive to Tylenol and Motrin that his mom and him have been trying. He cannot find a comfortable position to sit in his wheelchair. He's not able to sleep. He's had many sleepless nights. So he's really been pretty miserable for the last couple months. On exam, he's got full range of motion of his hip. However, motor strength is 4 out of 5 due to pain with all movements. So flexion, extension, adduction, and rotation. So as the practitioner, you're left with this question. In addition to, trying to figure out what happened, what was the POP, in addition to diagnostic imaging and likely referral to orthopedics. In the meantime, because he's living a miserable life, would you prescribe him opiates for pain? He's tried non-opioid medications and he's failed. So that's the kind of the context of the discussion today. Our goal is to give you a framework for prescribing opioids safely. And specifically, as I mentioned, we're going to discuss indications for prescribing opiates. I'm not going to give you exact indications or when you should or when you shouldn't. What I will go over are what the guidelines, available guidelines for pediatrics are for prescribing opiates. And a disclaimer, just so you know, there's not as much guidance as there is for adult patients. To provide contraindications for prescribing opiates, to develop a differential diagnosis of, quote, aberrant drug-taking behavior, unquote. So when something seems to be wrong, to give you a framework of what could be going on, and describe safer opioid prescribing practices. So we'll spend quite a bit of time about that, what the universal precautions of opioid prescribing are, so that you're keeping your patients and yourself safe. And lastly, we'll go over these not so new laws that went into effect 2018, at the height of the formalization of the scrutiny of physicians and prescribing. Governor Snyder and the state legislature passed laws in 2018 that are very strict with regards to what the physician must do when they're prescribing opiates. So why is this such a big deal? So chronic pain is a huge problem in the United States, in the world too, but the opioid epidemic is mostly confined to the United States. Chronic pain is a problem for 150 million people, Americans. Multidisciplinary options, which have been recognized as the best practices, even back in World War II time, multidisciplinary pain was recognized as the best way to manage pain. However, as we'll see, that availability is largely limited, and it's largely limited because the people who pay the bills don't pay for it. Opioid misuse and abuse has progressively worsened. And now that there's been less opioids, we're also now seeing the non-prescribed things like morphine or heroin and fentanyl on the black market has increased now again. And then there's been inadequate education for clinicians regarding best practices of chronic pain management. So basically, patients and physicians are left frustrated. So how about in pediatrics? It's estimated that 5 to 35% of youth have chronic pain. 14 to 38% of pediatric post-op patients develop chronic post-surgical pain, which is defined as pain that extends beyond 3 months after their surgery. One study of insurance claims, this is like 9,000 insurance claims, showed that 5% of previously opioid naive adolescents were still receiving prescriptions for opioids more than 90 days after their surgery. So that does show that a significant number of patients post-op, you think that pain should resolve within, 8 weeks when you have tissue injury. However, there's something about, for certain people, that this pain persists. So the specific risk of developing an opioid use disorder for adolescents and kids is not known, but it's thought that the risk is higher than in adults due to the changes of the reward habit formation centers of the brain. So, your brain is still developing in the adolescent age range, and we don't know exactly the risk, but we postulate that the risk is higher in adolescents. So this is just showing that the height of the opioid epidemic was in the early aughts, so 2010s, 11, 12. So, it was really ramping up during my years of training, 99 to 2003, when we had the makers of OxyContin sponsoring our drug, our lunches and stuff like that, and would talk about how the fact that long-acting pain meds cannot cause euphoria because of the slow absorption and all this kind of stuff that we now know is absolutely untrue. And they were postulating that the risk of developing a use disorder was less because of this slow absorption and all that kind of stuff, but we now know is absolutely false, and that probably many of the patients that we prescribed opiates to were probably harming them. But as the scrutiny has increased, you can see that the level of opiates being prescribed has come down. So back to my patient RC. So his x-ray showed chronically dislocated bilateral hips, didn't really show anything different than his previous imaging, which was a few years ago. But the orthopedic physician thought that the dislocation was in such a manner that it just prevented him from being able to find a comfortable position, but he did not want to do any surgery, and he wanted us to try and get him through this painful period, and maybe that hip would shift and his shift again into a more comfortable position for him. At the last visit, I didn't put on there, I had prescribed tramadol just because he had been in so miserable. He had no sleep. He was he couldn't sit still. He couldn't sit in a comfortable position in his chair. So that makes you feel uneasy, right? You prescribed an opiate, and that was the first uneasy feeling you had. But I felt like his pain was impacting his life, and I thought this very low dose of a very weak mu agonist opioid, I was hoping that it would get him to his goal, which was to just be able to find a place, a comfortable position for him to seat in his chair and maybe even get some sleep. But when he comes back and says, it's not helping, then you start thinking about other things. So the first question you have to ask yourself is this pain real? Unfortunately, there is no reliable guide for pain level. Physical exam and vital signs are very unreliable. You can't say, oh, he's not in pain because he's not tachycardic, or he's not in pain because he's not hypertensive. The adrenergic effects of being in pain aren't always reliably seen in all patients. Second, pain is a subjective phenomenon. It's subjective to the patient and it's subjective to the examiner, fraught with lots of chances for bias. And we know that even during the opioid epidemic and the crisis, that because of bias, actually, African-American patients were less likely to be prescribed opiates for their pain. So, what I'm trying to say is this is the part of the problem is it's a very subjective symptom. We don't have a test that can say, well, let's do a blood test to see if they're in pain or not. It's all subjective. So what I'm trying to say is there's no way on your first visit to know for certain if someone's pain is real or not. So is he drug seeking? You may hear that term used on rounds or in the clinic. And so what is meant by drug seeking? So one definition by Dan Alford at Boston University is it's a directed or concerted effort to obtain a medication. So this is kind of two things. It's hard to distinguish if a patient is inappropriately drug seeking, meaning wanting the drug for something that's not pain relief, or if it's appropriate pain relief seeking. So that's the conundrum the physician is left in. Should we prescribe opioids? As I mentioned, are they ever appropriate now that we know that the substantial risk that there is for developing problems? So is it ever appropriate for children and young adults? And if so, when is it appropriate? So to kind of get a framework for, is it appropriate in kids, I'll tell you what the guidelines are for adults. And, you know, there are a lot more concrete guidance in the adult world for prescribing opiates. And the CDC, the latest update is from 2016. They do put out periodic updates, which typically usually just lowers the maximum amount of dosage that a physician should prescribe before deciding that it's not helpful. So according to the CDC guidelines from 2016, the indications are that the pain has to be at least moderate to severe. I mean, some of these are pretty straightforward or common sense, I should say. It's that they failed to adequately respond to non-opioid and non-drug interventions, that the potential benefits are likely to outweigh the risks, that no alternative therapy is likely to pose as favorable balance of benefits to harms, and it should be used in combination with non-opioid interventions, never as monotherapy. And then that the patient has to be agreeable to have their use closely monitored. And that means frequent reassessments, that means counting the pills in their bottle, that means periodic drug screens. There should be a shared decision-making. This is, again, in the adult world. Of course, you'd be doing this with the parent if in smaller kids and with the adolescent and adolescents. The patient and provider should jointly discuss how to measure if the therapy is working and how to monitor for signs that opioids are harming the patient. So this is the risk-benefit framework of chronic opioid therapy. This is for chronic pain. You know, you have to discuss the risks, and you need not only to discuss these risks with the patient every time, you actually need to document this, because if you didn't document it in your clinic note, then this discussion never happened. You have to talk about the risk of accidental overdose and death, the risk of developing a substance use disorder. You need to tell them how illegal it is to sell the medications or buy it from other people. And then, of course, you just tell them about the other side effects of opiates: sedation, constipation, sexual dysfunction, and bone health. And then the benefits for opiate therapy, in adults at least, we know that about 1 in 2 patients receiving chronic opiates will have improvement in their pain symptoms and their lifestyle scales. And then, of course, you need to discuss alternative options to opioids. There are lots of things, again, because pain is subjective, evidence for each of these things is hard to get, you know, good randomized controlled trials looking at the effectiveness of each of these things. But my feeling is if it's unlikely to harm them, I think it's okay to try all of these things. One of the things that I've become interested in lately is acupuncture, and it's more of a abbreviated form. There's something called battlefield acupuncture that hopefully we'll be being able to offer in our clinic. It's 6 points in your ear. It's been shown, they do it over the VA, where they've reduced opioid prescriptions by a remarkable amount, I think the most in the country. And I saw a practitioner there do it for some of the patients, and it looks like it's really promising. So if you do endeavor upon prescribing opioids, the CDC recommends this, that you should start an immediate release. You should never start an opioid naive person in long acting. You should prescribe the lowest effective dose. You should reassess the benefits. If you're considering going above 50, and MME stands for milligram morphine equivalents per day. And then you should avoid going over 90 milligram morphine equivalents. So many places have reduced, some states like Colorado have reduced this guidance to you should assess the benefits if you're going above 30 milligram morphine equivalents, and you should avoid going above 60. And then last but not least, is probably the most important one when prescribing safely. You should never prescribe benzodiazepines if someone is going to be getting opiates, because the risk of accidental death is magnitudes higher when that combination is used. Okay, so the use of opioids for non-cancer pain in children and adolescents. So the CDC guidelines explicitly say this is for people older than 18. So I searched and searched to try and find a comprehensive pediatric guideline for prescribing opioids, and I found a few things. So there's the American Pain Society, and they just give a brief statement that says they're rarely indicated in the long-term treatment of chronic non-malignant pain in children, although they may be beneficial in certain painful conditions with clearly defined etiologies. So they suggest that obviously things like sickle cell disease, incurable degenerative joint and neurodegenerative diseases as examples. And I think most people would agree that that is a reasonable statement. And then I found other ones at other children's hospitals. I didn't find our local children's hospitals to have any specific guidelines. So nationwide at Columbus largely mimics the CDC guidelines. Only if the expected benefits for pain and function are anticipated to outweigh the risks. You should use short-acting opioids. The clinician should review the patient's history of controlled substance prescriptions, meaning they should check in the MAPS system, which we'll talk about, and then should prescribe the lowest possible effective doses. So largely kind of like the CDC guidelines. So the Pennsylvania state guidelines also kind of mimic the CDC guidelines, but the second and third bullet point are where they kind of diverge, where they actually recommend a specific opiate. So they think morphine or oxycodone should be used, and that we should be avoiding combinations with Tylenol, which is interesting to me. So that was just an example of kind of guidelines that are out there. So I looked to see if there are state guidelines, and if you Google pediatric opioid prescribing state of Michigan, guidelines, you'll come to this website. It's from the michigan.gov website, and you'll have a whole bunch of resources for you, okay? And the only thing I could find about pediatrics with regards to helping the physician figure out if they're going to prescribe opiates, are there any recommendations, was that they're very specific for specific surgical procedures, how many pills you should prescribe. And I think this is the effort to make sure that people are not overprescribing for post-op pain, so that to try and decrease the risk of future use disorder. But they're very specific. You can see for, maybe you can't see because it's very small, knee surgery you're supposed to prescribe 0 to 14 pills. There's some that you shouldn't be prescribing anything at all. So they're very prescriptive when it comes to the surgical things, but for our patients who are coming in for non-surgical acute pain, no guidance. Okay, so let's say we've decided to go ahead and prescribe opiates to our patient because we feel that the risks or the benefits outweigh the risks, and you've defined a specific measurable outcome with your patient to decide if what you're giving them is doing what it's supposed to. What are the other things you now need to do? So the first thing before you prescribe it is you actually should probably do this first before making the decision to prescribe the opiate. You should assess their risk of developing a future addiction problem. So the opioid risk tool is actually only validated in adults, but I did see some pediatric pain groups say they do use this and document it in their notes because due to the paucity of tools for pediatric providers. You should also assess if the patient is already doing something that would make prescribing the opiates unsafe, especially in adolescents. You should probably do a urine drug screen prior to prescribing opiates because if they have other substances already in their body, you know that they're either taking it from someone else illegally or using something, and that is very much an increased risk for opioid use disorder, if not already defined as an opioid or a substance use disorder. And if possible, if it's someone who's been getting pain meds from other places, you want to get records or speak to the previous providers. Okay, this is the opioid risk tool. It's basically a risk stratifying if someone is at risk for substance use disorder. So that's a family history, personal history of previous use of things. History of pre-adolescent sexual abuse is a very strong predictor in females for some reason. You get 3 points for that. And other history of psychological diseases. This is the COM, and it's not intended for you to actually see all of this. The COM is actually, if you've already prescribed opiate, this is the scale you'd want to use to assess if they're at risk of misuse of the medication that you're prescribing. And same with the SOAP. But for this audience, the one you're going to want to be familiar with is the CRAFT, which is a screening questionnaire that has been validated for alcohol and substances. I'm not going to go through, but if you Google all the questions and you'll see the scoring easily. You should be using the CRAFT to screen for the risk of substance use disorder in your adolescents. So which opioid? Like I said, you should be using the lowest dose. I use tramadol, which actually doesn't even show up as a morphine equivalent because it's that weak of a mu agonist. But you can see there's lots of opioid conversion tools out there that you can use to convert to morphine, oral morphine, which is the standard by which we decide how much we're prescribing. Okay, so are they helping or are they hurting? So how do you assess the benefit of your treatment, and how do you assess for if something is going wrong possibly? So as I mentioned, I think when you prescribe an opiate, you should clearly define with your patient what the outcome should be. So for my patient RC, we said, okay, I will prescribe this to you to help you try and find a position in the wheelchair that will help you be able to sit comfortably and that you're not in pain all day. And potentially even maybe it will help you sleep, although I try and avoid helping you get sleep as an outcome, because opiates, if you give them a high enough dose, will make people sleep, and it's not necessarily the best outcome. So you try and set a clearly defined goal, and you tell them, if it doesn't help, most likely we're going to stop and try and find other ways. I may send you back to the orthopedic surgeon to ask them to reevaluate whether or not something else needs to be done. So as I mentioned, you reassess at the next visit. He said he still was in pain and he couldn't find a comfortable place to sit. And so now it's been 3 months and he's still miserable. So if there's no improvement, you should consider stopping the opiate treatment. Okay. So when you are prescribing, you should follow the universal precautions of opioid prescribing. And these involve frequent reassessment of the response. So maximum interval when I start prescribing a patient opiates is 1 month follow-up. You should have in your practice a narcotic contract, or we have one for all controlled substances. So it just talks about things like If we are prescribing, then we will be the only ones prescribing, and we will be checking to see if anyone else is prescribing. And if anyone else is prescribing, we will stop prescribing. It talks about how if we start to notice that things aren't going right, that the use of the medication seems to be getting out of control, then we will stop it. If we find other things in your urine, which we'll be testing periodically, we will stop it. And you know, the reasons we're giving this medication is for X, Y, and Z. And these are the known side effects and potential adverse effects, and that we've discussed all these things and that they're still in agreement to getting this medication. So urine drug screening, some people advocate doing it every time. Other people do it sporadically. I think every time lends itself to some problems. We've now discovered that, you know, insurances will charge the patient if they feel like it's being done too frequently. So secondly, we also think that doing it sporadically when the patient doesn't know is more appropriate, because then, you know, you're more likely to find things like other substances, or actually them telling you that they took the medication last night and it's not in their system, et cetera, et cetera. Should be doing pill counts in an ideal world. I don't know. We didn't adopt this thing because we didn't want our patients to be riding in the bus or, you know, walking around with their oxycodone pills and stuff like that, because we thought that could be a safety issue. So we don't do really pill counts, but we definitely do the other things. And then of course the MAPS, which is, as most of you may be aware, the system that tracks what controlled substances prescriptions your patient has received. And then lastly, in the universal precautions of opioid prescribing, develop a differential diagnosis for aberrant behavior. So this is an example of our urine drug screen. I know it's very small, I'm sorry. We do not use the standard drug screen that the hospital uses that just has just the drugs of abuse. And the reason we don't do that is because we want to monitor if our patients are also taking their medications. So this drug screen, there's lots of different vendors who provide this service, but this drug screen will give you not just the level of the drug that they're taking, but also the metabolites to show that they're actually taking it daily, if you prescribed it daily. So part of the history taking on your follow-ups is, you know, how often are you taking it, and when in the last, you know, few days, how often have you taken the medication, so you can appropriately interpret your drug screen. Okay, so now we're going to talk about aberrant drug taking behaviors, and by that I mean it seems like the patient is requiring more and more, or asking for more and more, or things like that. So the first on the differential is unrelieved pain or pseudo addiction. Next is, you know, they've developed an opioid use disorder, which you hope you would, you know, stop before that. That they simply have developed tolerance. That something else is going on, that they have a psychiatric disorder and they're self-medicating. Or there's something more going on, like there's drug diversion. So pseudo addiction is just, you know, when a patient is that desperate for pain relief that, you know, they're desperate basically. So it could be because their disease is worsening, that the pain is opioid resistant pain, or they're getting withdrawal mediated pain. But the patient is intensely focused on obtaining relief, and the way you'll know this is if you find a better way to resolve their pain, all this behavior goes away. So for substance use disorder, you can think of the 4 C's. There's loss of control of drug use. There's compulsive drug use despite harmful effects on their life. And then there's craving. So the published rates of abuse and or addiction in chronic pain populations is wide. It's 3 to 26%. I think more recent studies would be more consistent with the higher rates than the lower rates. It suggests that known risk factors for abuse or addiction in the general population are good predictors for problematic prescription opioid use. So as I mentioned, when you do that opioid risk tool, use of any other drug or alcohol prior or a problem related to that substantially increases your risk. And in fact, probably should prevent you from prescribing anything to that patient. This is an adult, so adolescence it's a little murkier because most adolescents may be kind of in the experimental drinking and stuff like that. So, I don't have there's no good data to describe how much that previous behavior puts them at risk of an opioid use disorder. And then family history of substance abuse probably is a very important thing. So you're going to want to take a good history. So we talked about the risk assessment tools. I showed you the ORT and the CRAFT. You want to probably concentrate on those two. Okay. So if you have a different, one of these, if you have aberrant drug-taking behaviors and you've made a diagnosis of one of these things, then the following action is in red. So if you think the patient has pseudo-addiction, if they're on a low dose, you can consider titrating a low dose. But if they're on a high dose, you should refer them to a pain specialist if available. I would also put probably you may even consider focusing on alternative pain relief strategies. If you have a opioid use disorder, you'll need to refer to a substance abuse program and begin tapering the opioids. And I say it, so there's got to be considerable scripting, especially if you're with trainees, to be able to communicate this to a patient in a compassionate manner, and why you're doing what you're doing. If it's tolerance, if it's low dose, you should consider titrating, but I don't think that's a great idea. If it's, I think you need to start referring to pain specialists in those scenarios. If they're self-medicating, then you need to get them on appropriate treatment for their psychiatric or behavioral disorder. And then, if it seems like they may be selling, then you stop prescribing. One of the older internal medicine physicians here used to make us think about, not only should we stop prescribing, but do we have any obligation to tell the legal authorities? But I don't know if I have a very good opinion on that. Uh-oh, hold on, it's frozen for some reason. Okay, we're getting to the end here. So the last part, I'm just going to tell you all about the laws that you have to follow if you're going to prescribe opioids. It's also basically controlled substances in general. So all of these laws became effective June 1st, 2018. So to prescribe a controlled substance, you have to have a bona fide patient-provider relationship. That makes sense. So what does that mean? No prescribing to your family members, no prescribing to your friends. You should be only prescribing to someone who you have a record and a chart, and you documenting this prescription and the need for the prescription and your discussion of risks and benefits, et cetera, et cetera. Those are the only people you should be prescribing controlled substances to. I have seen physicians lose their license based on that, breaking that rule. The second part is that you need to do the opioid consent start talking form. There's a state of Michigan form. You could Google it and you can see it, and I'll show you an example of it. You have to, it states that you've discussed the risks, especially of addiction with the patient, the risks of accidental death, especially in combination with other meds or other substances, that you've discussed the side effects. You've discussed specifically that it's illegal for you to give this to anybody else or sell it to anybody else, and that you will dispose of it safely if you are no longer going to be using the medication. So this is the start talking form. This is version 2. Initially, there was some confusion. We thought that we had to do this form for even non-opioid controlled substances like benzos and ADHD medicines. But when I just looked on the website and preparing for this, it actually looks like you only need to do this form for opioids. It makes sense though, because the form completely is geared towards opioids and none of the side effects or anything makes sense with the stimulants and the benzos. Here are the other things. If you're endeavoring on prescribing more than a 3-day supply of a scheduled med, you must review MAPs. And it's very easy for people to check if you've done so. It's very easy for them to go in the system to see if you've checked the MAPs before prescribing the medication. So if you haven't gotten a login, you need to get a login now, and you need to check before every script that you send for your patient. You must check a MAPs. You know, even if I prescribe less than 3 days, I still do it out of habit. This is the MAPS website, if you haven't gone. And it will show you the last 2 years worth of controlled substance prescriptions. And it will give you a risk score. It's a risk score for the patient developing a problem with the medication and also their risk of accidental overdose. So for acute pain, you cannot prescribe more than a 7-day supply, okay? Okay, so in summary, it's impossible to determine if a person's pain is real on their first visit. Opioids can provide functional benefit in some. As I mentioned, in adults, it's about 50% for chronic pain. It's probably, you know, its role probably is a lot less than what we previously had thought. I'll just say it that way. Opioids can provide functional benefit in some with moderate to severe pain, not relieved by non-opioid medications and other pain relief modalities, in patients who are willing to be closely monitored and whose potential benefit outweighs their risk for harm. Proper ongoing monitoring for the effectiveness is needed for safe prescribing. Proper ongoing assessment for aberrant drug-taking behaviors is required for safe prescribing. Proper diagnosis of the aberrant behavior is required. They should be stopped if not providing benefit or when there's evidence of harm. And stressing patient safety is a compassionate way to stop or taper therapy when needed. And that's it.
Thank you very much, Dr. Rojas. This was very informative, and we appreciate you guiding us through this process. One thing that I wanted to let our audience know is that this counts towards our licensure in the state of Michigan regarding safe opioid prescribing. Are there any questions from the audience?
Yeah, Renato, since you do both pediatrics and adults, what's the youngest age, you know, this thing can get down to?
The youngest age, what? Say that again?
What's the youngest age you have seen, you know, getting addicted to opioids?
Oh, I'll be honest, I've been lucky that I haven't taken care of any adolescent or young patients who have developed a substance use disorder. I've seen plenty of adults, but not many kids.
Okay.
You know, where it gets murky, again, when you have chronic painful conditions, like I see Dr. Ravi's here, like sickle cell disease, I mean, I think it'd be, you know, without the appropriate tools to treat patients who are having an incredibly hard life like that, you know, it gets very hard to figure out if someone's having a substance use problem or just unrelieved pain. So, but I haven't seen any, thankfully, that have developed a problem.
Thanks, and it's so good to see you. Thank you.
Yep.
Dr. Ravi has his hand up.
Yeah, so Renato guessed my question already, but I just want to ask him how did it change the practice in sickle cell disease? Fortunately, I don't, or unfortunately, I don't take care of these patients anymore, and I have not done for a long time. It's probably more than 15 years since I prescribed any opiate to anybody. But what happens in the sickle cell world, in the adult setting, when they get admitted, what is happening there?
So the standard of care is to put someone on a PCA pump and to keep them on their long-acting oral pain medications that they get at home if they have any, and go from there. I mean, unfortunately, it's no different than probably the last 20 years. And, you know, because pain is so subjective, we have lots of adult sickle cell patients who feel like the PCA doesn't work as well with them as opposed to just getting pushes of IV Dilaudid at higher doses. And this is where, you know, the discomfort comes in, because again, you can't tell if someone is in pain or has a problem. So that's the problem we run into all the time, every day at the adult hospitals. I wish they would make those really good, I think there's some exciting gene therapies that have shown to improve, you know, I think they're still in early trials, but
Right.
I would like those things to become widely available to help this patient population, because just covering them with opiates seems to be a very, for many patients, to be a not great solution.
Dr. McGrath?
I remember this patient. Thank you for bringing him to my memory. How
He's
did
doing
he
much
do?
better. The follow-up is his pain had resolved, so something had shifted back, so he was better.
Oh, that's good. Okay, I took care of his ankles for probably years, didn't I?
Yeah.
Seemed like it. Thank you so much.
No problem.
Jen, you had your hand up?
I did. I just wanted to ask quickly, you have briefly mentioned, but could you talk a little bit more about the acupuncture? And you said that.
Sure. So what they do at the VA is not like a full-blown acupuncture, it's a simplified. So the theory is that your entire body is mapped to your ear, different parts of your ear. And they've identified 6 points in your ear that when you apply acupuncture needle will do lots of different things, but in this specific instance, it helps with pain, but it improves your sense of well-being. It can decrease anxiety. And, you know, again, like I said, it's very hard to have randomized controlled trials for this kind of thing. But, you know, the studies that are done show that it's effective in improving patients' lives and decreasing their pain, decreasing their anxiety, etc. And in fact, it's so successful, it's part of the multidisciplinary program at the VA hospital here in Detroit that at one point in time, I think 10 years ago, they were the VA hospital that prescribed the most opiates in the entire country. And they reduced their opioid prescription rates by like 70% or something like that due to use of things like acupuncture. It's so embedded in the culture at the VA that even the ER doctors there, if you come in with an acute pain, they will do ear battlefield acupuncture. Does that answer your question?
Yeah. Yes. Yeah. Thank you so much.
That's pretty cool.
Yeah.
Dr. Ayers, you had a
Yeah.
question.
I just wanted to back Renato. He actually answered it, but having had acupuncture done for chronic pain, it actually does work. And I think it's another modality that when my patients come in for pain, I do give them the option. There's another Afro-Caribbean practice called Reiki that, again, is similar to acupuncture, but uses it's without using needles, but just using the force of negative and positive force to try to move pain. And some people don't believe it, but when you have a Reikiologist and see it done to people that have pain, they do have some relief. And then just to back what Renato said, as far as Ravi is concerned, we do, with some of the patients that have been transferred from children's, we do ask them characteristic questions of how long they stay in the hospital, what has been their length of stay, what maximal pain medication or dosage they've been on. And for those who are not frequent flyers that often do not come into the hospital, they're pretty accurate. They'll say, I'll be here for 3 to 4 days. And we try to use that to gauge or get on top of the pain as acutely as we can so that it doesn't prolong their stay. Now, obviously, that's hard to do, and not every patient. And as Renato said, there are some patients that no matter what you do, they want to push no matter what. And so it does make it very complex and hard. And also the issue that we're having in the adult world is that the lack of finding a provider that wants to stick, and that's an MD, not a PA, but an MD that wants to assist and help is becoming very difficult within the area. With us, U of N and Ford being the major centers that have seen the most, but that is even more competitive because it looks like Dr. Sherney is moving some of her operations and some of her grant money to Henry Ford. So,
Yeah, very interesting. Yeah, this is definitely a timely topic on so many different levels. And we appreciate you, Dr. Rojas, for guiding us through. I know Jen will be sending out the link later on so that our audience can claim their CME credit. And again, this also counts towards your licensure in terms of education regarding opiate prescribing. If there are no further questions, thank you everybody else for attending, and we'll see you